In this video, we'll learn about chest x-rays. Again, a lot of students have been asking about chest x-rays, how to interpret for basic, USMLE and COMLEX. So here we go. Learn how to quickly interpret high-yield chest x-rays for the USMLE and the COMLEX. Again, these are the 5 objectives for the video. Develop a growth mindset, because again, a lot of students have a mindset where as soon as they see an image, whether it's a chest x-ray, a CT scan, or any other kind of images on questions, they freeze up. So this mindset will help you overcome that. Learn a general approach to chest x-rays. I will take a look at a normal chest x-ray and what are the different things that you want to pay attention to. Checklist for approaching a chest x-ray. Once again, mnemonics are super important and super helpful in remembering all the different things that we can look for potentially in a chest x-ray. And finally, we'll end with high-yield clinical chest x-rays for the boards. Okay, the mindset. Now, this is super important. As soon as you come across a chest x-ray or any other image really in a test question, take a deep breath and say to yourself, I can do this. Research has found that if one talks about themselves and talks to themselves positively during a test, that increases the chances of getting a question correct and overall increases the confidence. So I can do this. You can do this. Next thing is interpreting chest x-ray is a skill that you can develop over time, right? Super important. This cannot be learned overnight, but over time. The more you practice, the better you get. Instead of saying, hey, I am bad at reading chest x-rays, I suck at reading chest x-rays, instead say, I can get better at it with the right approach, right? So basic mindset. Next, we'll get into some general approach to reading chest x-rays. Super important. A lot of students focus on the image first. As soon as they see the question with the image, they try to interpret the image, right? Remember that both USMLE and the COMLEX, especially that I'm talking about step 1 versus level 1, both of these exams are at a basic science level, students who are transitioning from basic science to rotation. So you are not expected to know every single image that is in front of you. So never look at the image first because that will just create a lot of tension and anxiety. But instead, get context from the question first. Super important. Based on the age, sex, chief complaint, based on what is given in the question, whether it's an abnormal finding, whether it's a normal finding, definitely get those context from the question, some clues from perhaps the labs or even the physical exam finding, right? So all of those will help you formulate a most likely diagnosis. Then take a look at the image to confirm your suspicion. Super important. Increase the brightness of the screen to clearly see details. And again, what you can do is, even on the exam day, right before you start your actual test, when in the Prometric Center, you can ask the proctor to show you how to increase and decrease the brightness of the screen so that you can do that as and when required during the test taking. All right, so here we have a normal chest x-ray, very high yield slide. Right here at the top, we have the apex of the lungs. We have the first rib, and this is the clavicle on this side. Same thing here, clavicle on this side. Then we take a look at the trachea. And as we are going down, we look at the tracheal bifurcation right over here. We have the superior vena cava coming right over here and entering the right atrium of the heart. We have the thoracic vertebrae right here, which again, if you increase the brightness of the screen, you will be able to see that. We keep going down on the right side. We have the right atrium border of the heart. We have the right cardiophrenic, make a note, not claustrophrenic, cardiophrenic angle, the angle that the heart border makes with the right hemidiaphragm, the cardiophrenic angle. And right underneath that, we have the inferior vena cava, which is bringing in blood from the bottom of the body to the right atrium. Right here, we have the right hemidiaphragm, and this is the right claustrophrenic angle, right claustrophrenic versus right cardiophrenic, two different things. On this side, we talked about the clavicle before. On the left side, as we go down, we have the aortic arch, which is coming from the left ventricle comes up into an arch and then forms the descending aorta. So right over here, this is sometimes called the aortic knob, K-N-O-B, aortic knob, or the descending aorta. And right underneath that, we would have the pulmonary trunk, which is bifurcating and supplying, taking the blood from the right ventricle all the way into the right and the left lung. Some pulmonary markings right over here. As we further go down, left atrium border, and of course, this overall is the heart right over here, the left ventricular border, and now the left cardiophrenic angle, and the left hemidiaphragm, and the left costophrenic angle. And right underneath the diaphragm on the left side, if you see some black or dark space, usually dark or black is air in the x-rays, so this would be gas in the stomach. Right? So these are all the major areas that you want to look for in a chest x-ray. Now that you know the normal, you'll be able to easily pick out what the abnormal might be. All right, so for a very quick basic approach in terms of chest x-rays, we have the mnemonic ABCD, EFGH, right? So airways. Now in airways, what you're looking for is predominantly the trachea, right? Is the trachea deviating to the left or the right side, right? If it's deviating to the opposite side, you're thinking perhaps a tension pneumothorax. If it's deviating to the same side, you're thinking atelectasis, right? So now we're, with each of these slides moving from this slide, we're going to add a bit of the clinical perspective or clinical correlations here, right? So trachea, look for deviations either to the same side as the issue or the opposite side. The next thing you want to look at is you want to follow, and again, thinking back to right here, you want to follow the trachea as it bifurcates to the right mainstem versus the left mainstem bronchus. Right. Other than the trachea, you also want to, at that point, look for any kind of tubes which the patient may have, pacemakers, if that's given, right, pacemakers, any lines or any other foreign bodies. Right, so those are the main, couple of main things that you want to look for. Foreign bodies, B for bodies. At that point in the airways, you can also look for a widened mediastinum, wide mediastinum. You can write that over here, wide mediastinum. A couple of things to watch out for with wide mediastinum, which both the COMLEX and the USMLE love to ask you. Any tumors, any mass lesions, any lymph node enlargement, any infection of the mediastinum, mediastinitis. You could also think for granulomatous inflammation like sarcoid. You can also think of hematoma due to some trauma, blunt force trauma to the chest. You can also look for aneurysm, aortic arch aneurysm, or even dissection. All of those can cause a viral mediastinum, including anthrax, pulmonary anthrax to be specific. Right? So those are the things to look out for in the airways. Bones, you want to look for fractures. That's a big one. Fractures, dislocations, displacement, subluxation, any of those. You can also look for osteolytic versus osteoblastic lesions. Osteolytic versus osteoblastic. You can also look for arthritic changes, right? So osteoarthritis, that's a big one. You could also look for subcutaneous air. Sometimes you can find air in the subcutaneous tissue due to some pathologies, foreign bodies, and clips, very similar to airways. Right? So under B for bones. The next one, C, is for cardiac. Look for the heart. Heart borders, regular, irregular, any enlargement. Any enlargement. Sometimes you can also find a very thin rim of air around the heart. That would be a pneumomediastinum. Pneumomediastinum. Pneumomediastinum, a thin rim of air around the heart. At this point, you can also look for the aorta, any widening, any tortuosity. So those go in hand, aorta. You can also look for any calcifications on the valves. Calcifications, right? So either in the aortic valve, mitral valve, any of those. At this point, you can also look for, if you have not already done so, SVC, IVC, any of those. All right. The next one, diaphragm, D for diaphragm. Now, note that normally the right hemidiaphragm is higher than the left, right? Right hemidiaphragm is higher than the left. If it's a lot higher, if it's significantly higher, then you're thinking of effusion, lobar collapse, consolidation, any of those, right? Sometimes you'll also be able to find infiltration just in that area. And depending on what else they're presenting with, if the patient presents with sudden onset acute abdominal pain and they are in the ER, look for a very, very important finding. This is tested in multiple points, multiple questions. We call it free air under the diaphragm. Free air under the diaphragm. And this one suggests a perforation, a GI perforation. And then we have E for effusion. Effusion, usually you'll find blunting of the claustrophrenic angle. If they say blunting of claustrophrenic angle, you have your diagnosis. It's some sort of effusion. Claustrophrenic. Claustrophrenic angle, right? And at this point, you can also look for the pleura. Any calcifications, thickening, or even pneumothorax. That's all part of effusion. Thickening, calcifications, or pneumothorax. Then we have F for fields, and usually they mean lung fields. Lung fields, very, very important. Infiltration. Now, if they have interstitial infiltration is usually called reticular. They use the word reticular. And again, of course, they won't have reticular on the X-ray, but in the question, look for reticular. That means interstitial infiltration. And if it's alveolar, A for alveolar, alveolar infiltration, they usually use patchy. Patchy or even nodular. In the lung fields, you can also look for tram tracking. In the next few slides, we'll talk about what this means clinically. Bronchiectasis, described as parallel lines. missed a C here, tracking, tram tracking. And you can also look for curly B lines. Curly B lines, these are found in congestive heart failure or pulmonary edema. And in the lung fields, you can also look for, of course, a pneumothorax. Pneumothorax, we've talked about it in a lot of different contexts here, but pneumothorax, cancers, tumors, and even granulomas. So all of those could be found in the lung fields. G is for gastric air bubble. We saw that in one of the previous slides. Check that if it's in the correct position, if it's on the right side and not the left side. So that opposite, it's on the left side and not on the right side. Sometimes you can also find a hiatal hernia. So let me first write down gastric air bubble on the left side. Hiatal hernia. Look for free air underneath the diaphragm. That would also suggest perforation, so you can find that here. And sometimes with the hiatal hernia or any other hernia in general, which is going to the diaphragm, on the left lung field, you'll be able to find loops of bowel, as in bowel loops inside of the left thoracic cavity. So those could be associated with hiatal hernia. And for H, hilum, you're basically looking for one major thing, well, two major things. One of them is enlargement of the lymph nodes. Enlargement of lymph nodes. Second thing, any calcification of those same lymph nodes. So any calcified nodules, any mass lesions, any tumors, any cancers, any of those you can find over here. All right, so here we have our basic checklist for approaching chest x-rays. Next slide. So now we get into some more clinical aspects. These slides, including the images, are super high yield for both USMLE and COMLEX. Chronic bronchitis versus emphysema. So both of these are COPD, chronic obstructive pulmonary disease. The definition is super important because this is mentioned in the question. How does a chronic bronchitis present? Again, why is this important to note and not just focus on chest x-ray? Because they won't give you just the chest x-ray to interpret. Remember, this is not a rotation. This is not a clinical rotation. This is not a clinical clerkship exam. This is a basic science exam. USMLE and step 1 and the level 1, COMLEX level 1, these are basic science exams. So they always will have clinical context in the question. So the clinical context in here would be productive cough that lasts for 3 months for 2 consecutive years. Very important. Cyanosis, super important with chronic bronchitis. They could develop peripheral edema from right heart failure. And one thing we find, which is pretty common in these patients, is these are obese patients, usually. They may or may not mention a history of smoking. So as long as they have this particular scenario, you're thinking chronic bronchitis. On the flip side, emphysema, look for an older patient with a smoking history. Very important. These are also called pink puffers. These are called blue bloaters. Blue bloaters, chronic bronchitis, pink puffers, emphysema. Pursed lips breathing, very common. They also use their accessory muscles. They have a very cachectic appearance. They appear very thin, older and thin patient. Barrel chest. Why the barrel chest? Because emphysema, because it's a COPD, patients are holding onto air. And when you tap, when you do the physical exam, hyper resonant to percussion, meaning they're holding onto air. Anytime we have a lot of air in the lungs, hyper resonant to percussion. Right? Chronic bronchitis, anterior posterior diameter usually is normal. Increased bronchovascular markings, enlarged heart with cor pulmonale. And what exactly is a cor pulmonale? Anytime due to chronic lung condition, in this case, let's say it's chronic bronchitis, chronic lung conditions, what happens is the patient is in a state of hypoxia, right? So decreased oxygen. What that does is it causes vasoconstriction. VC stands for vasoconstriction in the lung blood vessels, which puts a lot of pressure back towards the right ventricle, right? Which means the right ventricle has to pump a lot harder. Eventually, there's right ventricular hypertrophy, and there's very minimal space for the blood to come inside. And if this is going on inside the heart, this again, it does not happen overnight. It takes years to develop. So it's a chronic process, and that's why the term chronic bronchitis patients may pass away because of this, and that's called cor pulmonale. I don't have a chest X-ray for this one because it's a very non-specific finding. As long as they have this clue and you have the cyanosis, and again, they give you a chest X-ray, you know that, hey, this is most likely chronic bronchitis. Emphysema, on the other hand, the anterior posterior diameter is increased. Remember, the anterior posterior diameter is if you measure the diameter from the anterior chest and the posterior chest. Because emphysema patients are holding on to air, the AP diameter is increased. Because they're holding on to air, it pushes the diaphragm at a very low level. You see how the chest X-ray here, it's elongated. The chest X-ray itself, the chest itself is elongated, right? So the hemidiaphragm is flat, decreased cardiac silhouette. Normally, the heart should be all the way up until here, right? But it's slightly on the right side and it's elongated. It's more midline and slightly to the right side. And decreased vascular marking. You don't see a lot of blood vessels right over here. It's pretty even surface. That is emphysema. Next up, we have bronchiectasis, another one of those COPD pictures, right? Or not really COPD specifically, but more obstructive lung condition. All right, so the clues for this one would be chronic cough. Chronic cough, copious sputum. Now again, cough could be medications, could be asthma, could be COPD, could also be bronchitis. So I wouldn't use chronic cough as, hey, anytime I see chronic cough is bronchiectasis, it could be so many different conditions, right? So think of other things: copious sputum production, blood in their cough, so hemoptysis, and recurrent lung infections. Pseudomonas and Staph aureus infections are very, very common, and these patients are also associated, or this condition is also associated with cystic fibrosis. Cystic fibrosis. Pseudomonas infections and staph infections. Very, very common. And again, these are all lung infections predominantly. In one of the previous slides, we mentioned tram tracking. Now, tram tracking is a very important feature of bronchiectasis. All these are parallel narrow lines, right? Parallel narrow lines radiating from the hilum. So as you can see right over here, these are all the tram tracking. A lot of cystic spaces, and sometimes can be described as a honeycomb-like structure. Honeycomb can be seen on an X-ray, can also be seen on a CT scan. Right? So honeycomb is not specific to an X-ray finding, could also be in a CT scan. Then we have interstitial lung disease. Interstitial lung disease, again, there are so many different types of interstitial lung diseases. This one specifically is comparing pulmonary fibrosis and sarcoidosis. Shortness of breath, non-productive cough, crackles. Now, this is a testable point. Certain questions I've seen on UWorld as well as the ComBank, they describe crackles specifically with pulmonary fibrosis as dry, fine, and end inspiratory. So this is a very, very important clue for pulmonary fibrosis. The signs and symptoms, I've not really mentioned anything here because it's very non-specific. A lot of lung conditions can have the same thing, so it's not worth a mention here. On the chest X-ray, decreased lung volumes. Why is that decreased? Because interstitial lung disease is the same thing as a restrictive lung condition. Obstructive, they hold on to disease, hold on to air, meant to say there, and interstitial lung conditions, they're not holding on to air, right? So they're breathing everything out, so the volumes overall are decreased. Now this is important. Reticular, nodular, or reticulonodular pattern. Hey, you see that honeycombing is not only specific to bronchitis. Honeycombing, we can see it over here as well. And they could also have hilar or mediastinal lymphadenopathy. Hilar usually is talking about this region right over here. That's a hilar region. Compare that to sarcoidosis, which is also an interstitial lung condition, which is also a restrictive lung condition. Look out for clues, young to middle-aged African American patient. Now, make a note, African American may or may not be given in the question, so you have to look for other clues. Sometimes they mention Scandinavian descent or coming from northern climates like Canada. Cough, fever, short of breath, again, those are pretty standard. All three we can also find in pneumonia and other lung conditions, right? So you want to look for other clues. Joint pain, this is important. Joint pain, erythema nodosum. Erythema nodosum is a skin condition. This is on the shins, And uveitis. Uveitis is collection of WBCs, white blood cells in the anterior chamber of the eye. So sometimes we have the anterior or the posterior uveitis. And we can also have hepatosplenomegaly because of granuloma formations in those areas. Okay? So those are some of the clues to look for with sarcoidosis. The way they describe the chest X-ray, nodular opacities in the upper zones of the lungs, and a bilateral, so this is bilateral, hilar lymphadenopathy or adenopathy. This right over here. Bilateral hilar lymphadenopathy, sarcoidosis. Then we have pneumoconiosis. Now make a note that all of the pneumoconiosis are also part of interstitial lung conditions, or in other words, restrictive lung conditions, right? One of the examples we have here is asbestosis. I've included asbestosis here because they either give you a chest X-ray or they describe to you what is a chest X-ray finding. So very, very important. With asbestosis, the clues are super, super important. Anytime they describe to you a patient who is working in the insulation department, shipyards, brake lining repair, pipe fitters, or even plumbers. So all of those are risk factors for developing asbestosis. Again, doesn't happen overnight. It can take 20 years or more to develop this condition. Make a note, shortness of breath, non-productive cough, and clubbing are pretty non-specific, right? So we have a lot of differentials for these three signs and symptoms. So you have to look for other clues like here. Right? In terms of chest X-ray, this is probably the only condition that the boards test on which has pleural and diaphragmatic plaques and even calcifications, right? Very, very important finding. So here is where you can see those plaques. So calcifications, anything white is usually bone or like calcium or calcifications, and these are what you can see here. Diaphragmatic calcification would be right here. And here are the pleural calcification. The red arrows are the pleural, and the yellow right one here, this is the diaphragmatic. And finally, pleural effusion. Again, pleural effusion, there are so many different causes. You always have to get the context from the question. Pleural effusion is fluid collection inside of the pleura. Is it a heart failure issue? Is it a cirrhosis? Is it a nephrotic syndrome? Pneumonia, right? Malignancy. These are all the major causes of pleural effusion. Some signs and symptoms, again, pleural effusion, very, very important finding, especially on a physical exam. So decreased tactile fremitus. You guys remember back from basic sciences when in the physical exam class, you were asked to place hands on the patient's posterior chest, either this way, or sometimes just kind of placing them this way, and then having them say 99, right? So tactile fremitus. would be decreased. Dullness to percussion, because fluid, anytime we have fluid, either in the abdominal cavity or the lungs, decreased. Decreased tactile parameters that's in the lungs, and dullness to percussion. Dullness to percussion, whether the fluid is in the abdomen or the lungs. And then we have decreased breath sounds because the fluid is covering that area. And here we can see a normal costophrenic angle, and the left costophrenic angle on this side is blunted. A lot of white opacity, so that is fluid collection. Right? So that is pleural effusion. All right, and another important one, bonus one, we have tension pneumothorax. Tension pneumothorax, we have penetrating or a non-penetrating injury. Central venous catheter, sometimes they describe a patient who just underwent a central venous catheter replacement or mechanical ventilation or thoracentesis, and all of a sudden they develop acute onset pleuritic chest pain. Right? So that makes us think of tension pneumothorax. COPD patients, chronic obstructive pulmonary disease, lung disease, those patients can also develop pneumothorax. Sometimes they could develop a spontaneous pneumothorax, and some of the clues for that might be smoker or a male patient. Marfan syndrome, because of the rupture of subpleural blebs, they can develop Marfan syndrome. Now, super important, tension pneumothorax, you have to pick this up on the question. If the patient is in the ER, they are in acute distress, they have acute sharp pleuritic chest pain, short of breath, tracheal deviation to the opposite side, and features of shock, meaning decreased cardiac output and hypotension. Right? So those are very important. Hyperresonance. Now, anytime when we tap on the lung fields, and whenever there is a lot of air collection, that one represents hyperresonance. That one means hyperresonance. The side that is affected, right? The side that's affected, you'll have decreased breath sounds because of air that is compressing on that particular side of the lung, right? So that's tension pneumothorax. Separation of the visceral and the parietal pleura, seen as a fine, this is super important, fine crescentric line parallel to the chest wall, right? So if you see right here, we have, and again, let me enlarge the image here. We have the red arrow, tracheal deviation to the opposite side, and we have the tension pneumothorax. So if you can see this fine line, which is parallel to the chest wall, right? This area is complete dark, meaning the lung is compressed and is pushing towards the opposite side. Classic for tension pneumothorax. Tension pneumothorax. So guys, those were all the major points that you want to know for picking out important chest X-ray findings in the lung fields. Thank you.